Enter that now. All right, so welcome to tonight's presentation, guys. My name is Amanda Reichart. I am the managing registered dietitian here at Functional Nutrition RX. Christina is our owner. She helped, of course, in making this tonight, but she is not available. But we will be sending this out to everybody again in within 24 to 48 hours, along with actual meal plans that will correspond for each week of the cycle. So I want you to see tonight's presentation as like a general intro to root cause nutrition for general cycle health with an emphasis on PCOS. This is a very in-depth topic that we do plan to go even more in depth, but tonight will be a great introduction. So what I want to first cover is what we're going to touch on tonight, right? Understanding cycle health. We're going to explore of course, the general cycle, go into what that means, key phrases, the phases of our cycle, what are the main hormones at play, how nutrition impacts those hormones, more from a macronutrient standpoint. We will touch a bit on micronutrients. I do plan to go more in depth on that in subsequent seminars. Common abnormalities that women face when menstruating. What is PCOS? What is the most common diagnosis criteria? How different metabolic imbalances impact that? And of course, how PCOS impacts us from a metabolic standpoint with an emphasis on our cortisol and, of course, our insulin or our blood sugar. We'll touch a bit on inflammation, especially we'll go into different functional testing that we offer here at Functional Nutrition RX, some key labs that we want to hone in on, and I'll explain what those labs mean. And we'll also touch on supplementation to correspond with PCOS and general cycle health. So what are these hormones essentially? We hear that women have such a complex menstrual cycle and hormone cycle, but what does that really mean? What is this orchestration that is going on? So if you're questioning if your hormones feel off, it's extremely common for women to have these questions because it's normal to have about 1 to 3 periods per year that might be a little off where we feel sick. And it's influenced by many different factors throughout our lifestyle, right? So why does this happen? Hormones are kind of like blood sugars. They fluctuate throughout the day, throughout the month, really, and it's impacted by stress, sleep, food choices, overall lifestyle. So, of course, when we're talking about the menstrual cycle, I want you to refer to the image here on the right of your screen. So, we're going to look at the top, shows follicular development from menstruation here on the far left line. And you can see on the very bottom, it says 0, 2, 4, 6, 8, 10, etc., all the way to day 28 across here. So it's giving you a depiction of the follicular development here at the top. And then in the middle, of course, the pituitary and ovarian hormone levels. So it's referencing essentially what you call the hypothalamic pituitary ovarian axis, HPO axis. And then, of course, the endometrial cycle on the bottom, which is showing you how the endometrial lining, which lines our uterus, changes throughout the 28-day cycle. So a healthy cycle can vary from about 25 to 35 days. So even though this says literally 28 days, your cycle may vary and might not be 28 days, but it doesn't mean it's not healthy if it's not exactly 28 days on the nose. You want to notice though if there's deviations in your cycle, which we will get to. So when we first start off, you see that endometrial lining is shedding. Typically days 1, 0 through 4 is our period, right? Menses. Of course, you see the hormones between that pituitary and ovarian hormone level section are kind of like leveled off, right? You see FSH in green, our follicular stimulating hormone, our estrogen in yellow, our luteinizing hormone in red, and our progesterone in blue. So one that you don't see going through is testosterone in this image. You do want to see testosterone is relatively consistent, where it does blip up around ovulation right in the middle of our cycle on this graph, day 14. So what's going on is our FSH and our LH are steadily rising. That's our pituitary releasing these two hormones to get the ovaries ready to release an egg, right? So the luteinizing hormone is telling the body to pass that egg along. The follicular stimulating hormone is telling our body to, produce that estrogen and release the egg as well. So you're seeing that estrogen steadily rises, that yellow line, up into like a mountaintop peak around that ovulation, and it comes right back down until on this graph you see that it starts to come back up as a small hill between days 18 and 24. That's important to reference, especially in that area of what you call the luteal phase, that second half of our cycle, as progesterone, you'll see in blue, is pretty steady. It's pretty steadily low that first half of our cycle, which you call your follicular cycle. And then it pops up similar to estrogen between days about on this graph starts to increase around 16 and then comes down around days 28, right before someone's to get their period. When we do labs, we'll get to this more. We like to look at that balance between progesterone and estrogen, especially in that second half of that cycle, where you see progesterone is supposed to be higher than estrogen, and you see estrogen falling just lower than progesterone towards the end of our cycle. So that's going to be important. I'll go back to this slide when we talk about estrogen dominance, low progesterone, high progesterone, what that means, high estrogen. On the very top, going across that follicular development, we have the menstruation, of course. So there isn't an egg fully developed in our ovaries that starts to develop after, of course, our period ends. And then around ovulation is when it's at its peak. If that egg is no longer fertilized, is when the egg turns into what's called the corpus luteum. And then when that's passed along, that's when your body, you notice as that corpus luteum starts to change from an egg to corpus luteum, progesterone also starts to increase. It's secreted from that we'll call, organelle, right? From that hormone organ, that corpus luteum. Now, if the egg is fertilized, of course, the uterus will start to thicken the lining. Progesterone will increase, but for different purposes. But typically, progesterone is much higher in the second half of our cycle than in the first half of our cycle. And you see a big surge in most of our hormones, except for progesterone, around ovulation, that midpoint. And that's often when we're feeling pretty good and when activity, if we're exercising, is, we're able to perform well. So when sex hormones go off track, right? So some common symptoms that we hear here at Functional Nutrition RX is fatigue or brain fog. Some of our patients come in with unexplained weight gain. I haven't changed anything in my diet or, my exercise regimen. I'm starting to notice changes in my weight, hair loss, because the thyroid also plays a role in this as well. Nutrient needs play a role in this. Anxiety, PMS, low libido, fibrocytic breasts, painful or heavy periods, irregular or frequent cycles, insomnia, feeling easily stressed or emotional. I have a lot of women that will say, I'm feeling very emotional and I know rationally I'm not upset about anything. I don't know why this is happening. Joint pain or muscle aches, cold intolerance, and blood sugar imbalances. So we're going to talk about these symptoms and what they could be impacting. So we're so blessed to be women in that our cycle gives us like a clue. It's another vital sign to tell us about our bodies, right? Men don't have this vital sign. And every month it does tell us about our lifestyle and how this communication loop between our brain, specifically our pituitary, our ovaries, and our hormones, how that loop is occurring, and what's going on in our body. And then each phase sends different signals about what's going on, right? So, of course, menstruation is those days 1 through 4 where we're getting our period. The follicular phase is that first half of our cycle until ovulation occurs. And then, of course, we have ovulation, which marks the end of the follicular phase and the start of the luteal phase. When I see luteal phase, I think of the moon, and that's what helps me to remember that's the second half of the cycle, compared to the follicular phase. So, with the follicular phase, estrogen is rising as we saw, right? Until that peak around ovulation. And of course, like we might be feeling higher energy, motivation, increased focus, because estrogen does help us with, cognition as well. We'll get more into what each of the hormones does and the roles that they play. You might find during that follicular phase an increase in workout intensity that you can be able to buffer or stand. Of course, we need more protein during the follicular phase to help with that follicular development, especially if fertility is a concern for us. And especially protein does help in the later half of our cycle with the development of that uterine lining, along with a lot of other nutrients too. Antioxidants also help to protect that maturing egg from oxidative stress. And again, if fertility is something of interest to you, CoQ10 also is a nutrient that helps with mitochondrial energy within the follicles. B vitamins help with follicle, or that's like the egg, the follicle development. Of course, DNA synthesis, the creation of DNA. And of course, later on in our cycle helps with endometrial development and the development of different hormones. The luteal phase, that second half, typically days after days, 12 to 14, and lasts about 12 to 14 days of our cycle. That's when that corpus luteum forms, right? That mature egg is now being passed along, and is going to be excreted from the body. Progesterone rises. You'll see a bump up in our temperature, our body temperature, especially around ovulation. Magnesium is helpful during this time of our cycle, especially paired with B6 to help with mood, especially if there's cramping. Magnesium can be helpful for cramping symptoms in that later half of our cycle, as well as omega-3s in that second half of our cycle as almost like an anti-inflammatory. Omega-3s that come from like salmon, tuna, fatty fish, herring, anchovies, mackerel, in particular. You can get them from, of course, like different plant-based forms. It's not as bioavailable or easily absorbed when it's in that plant-based form, but chia seeds, walnuts, Brussels sprouts will also help that. We also want complex carbs in that luteal phase as well to help with that progesterone development. So I just wanted to touch on that lightly and what those phases are, because you might be seeing a lot of that on the internet. When you look up this cycle, you might see it on social media. That what exactly does it mean, the luteal phase versus the follicular phase? And essentially, it's just dividing the cycle in half, where ovulation notes the end of that follicular phase and the start of the luteal phase. Estrogen is one of the key female reproductive hormones. It peaks in the days leading to ovulation, like we were saying, which is our most fertile period. It also thins the cervical mucus to facilitate sperm development and helps make intercourse more comfortable. You will actually see, thicken, I should say, not thin. You'll see around ovulation that egg white like discharge, to help with that stickiness, to help with that sperm adhesion. Pregnancy, of course, estrogen promotes the maintenance of pregnancy and prepares the breast for lactation. It helps with sexual development when we're going through puberty. Estrogen is so important, especially to note after we start to go through menopause, as it does help to maintain and protect our bone density. It helps to inhibit that breakdown of bone, which is why women are more susceptible for osteoporosis as their estrogen levels drop after menopause. So, of course, menopause is that 12 months we go without our period. That's to note the start of menopause, that we have entered from perimenopause into menopause. Estrogen protects our heart, so that's why risk for heart disease increases once we enter into menopause, right? So it protects our blood vessels partially by increasing that good HDL cholesterol and helps to decrease that bad cholesterol. It helps to grow cells and increase blood vessels and tissue thickness too. So it does help our vasodilation in that part. Brain function. It affects our cognitive processes, which is our decision making and our learning. So it does help to play a role in mood regulation. It plays a role in metabolism, influencing appetite, fat distribution. So as we enter into menopause, a lot of patients will note, I'm feeling, an increase in this midsection or visceral adiposity as estrogen promotes fat storage more so around the hips and buttocks area. So that also can indicate, a little bit about estrogen status based on where you are more prone for storing your body fat. It contributes to skin elasticity, helps with our collagen. So, of course, it gives us that vibrancy in our skin. Other systems as well that estrogen impacts is the health of our urinary tract, again, and how it impacts our tissues, our mucous membranes, our pelvic floor muscles. So, estrogen is definitely an important tool to test. We will look at estradiol often in the labs, which tells us about how much estrogen our ovaries are producing. And then we can also look at your body's total estrogen as well. Too low a estrogen can indicate vaginal, can cause vaginal dryness that because of that tissue breakdown, of course, right? Especially that sensitive tissue, lower mood, brain fog, and fatigue. Higher estrogen can be seen with, more symptoms of PMS, heavier periods, and breast tenderness, which we'll get into. So, core functions of progesterone, because when we're talking about menstruating women, progesterone and estrogen tend to go hand in hand. So, core functions is that progesterone is responsible for building and maintaining the uterine lining. It supports the follicular development. So, as we go from ovulation into the luteal phase, of course, that corpus luteum, that egg now that is getting moved along that was not fertilized is now turned into the corpus luteum, which secretes that progesterone. That's why you see that increase in that second half of your cycle after ovulation. It stimulates cervical mucus production, enhances insulin sensitivity and metabolic flexibility, protects the brain. It helps us to feel good, feel safe, feel lower stress would be the better way of phrasing. It maintains vaginal tissue, moisture, elasticity, as it does help with balancing with estrogen. It supports strong bones and collagen formation and helps with the regulation of cardiovascular health. So the primary role when you think of progesterone, I want you to think of that thickening of the uterine lining in reference to just going through your cycle into your period, right? Not necessarily fertility. So if you have low progesterone, that lining isn't really getting built up that strong. You might be experiencing more spotting. That can be a sign. Lower mood, shorter cycles, brain fog, fatigue. If it's too high, PMS, heavy periods, longer cycles, and breast tenderness. Follicle stimulating hormone and luteinizing hormone. These two are often looked at together because they're both uh, released and peaks around ovulation, but it's also released from the pituitary. So FSH, follicle stimulating hormone, its role in the cycle is that it's released earlier to recruit and grow follicles. It helps to choose the dominant follicle and sets up estrogen production. When it's off, if you have high FSH, ovarian stress, or low estrogen, right? We tend to see that rise as we go through our cycle with FSH and when we enter into menopause. Low FSH can be a sign of irregular or absent ovulation, especially in relationship to LH, luteinizing hormone. Luteinizing hormone creates this surge, this LH surge. So you might see women measuring their LH when they're trying to get pregnant because that also helps to connote, when they're ovulating. It surges mid-cycle when estrogen peaks and it signals that egg release for ovulation. So now it can be fertilized. It triggers progesterone production after ovulation as well, because it's saying, okay, we're going to release the egg and now it's turning into the corpus luteum. So it signals the end of the follicular cycle into the luteal cycle. When it's off, the pituitary can functioning gets reduced, especially in times of stress. So you'll see more of a push towards cortisol and a change in ratio from FSH to LH. You might find providers, especially like an OBGYN, or will measure this here in the beginning of our cycle, measuring that relationship between the luteinizing hormone and follicular stimulating hormone as a sign, but not a diagnosis criteria for PCOS. Weak LH surge can indicate an ovulation that we didn't ovulate, but we're going through our cycle, right? The shedding of that uterine lining. A shortened luteal phase as well. And it might indicate potential for PCOS. Testosterone. It's not just men's best friend, but it's our friend too, right? So women produce testosterone as well, not as much as men, but we do produce testosterone. So what it does in our cycle is it boosts libido. It can give a confidence boost, energy. So it peaks at its highest around ovulation, along with many other hormones. It supports muscle building and metabolism. Of course, more testosterone, more likelihood we are to build muscle. The more muscle we have, the faster our metabolic rate. It helps to regulate mood and motivation, supports egg quality and ovarian function. Why it matters, if low testosterone could mean low libido, low energy, poorer muscle tone. And when we're in our younger years, we want to try to put on as much muscle as we can for when we get older, and it's harder to build that muscle and keep us, metabolically flexible as we get older. Higher testosterone, though, when it's out of range, which is very common with PCOS, you might see more acne, hair changes, right? Especially the bald spots, depending on when it, broke down, uh, how it's breaking down, and what metabolites it's breaking down to, or irregular cycles. A healthy pattern is having that small baseline with that brief peak around ovulation and then a gradual decrease throughout the luteal phase, pretty steady. So when we look at our period, again, we're very blessed. It gives us a peek, a window into our body, just like another vital sign, like our blood pressure, for example. So it's important to note that everyone's an individual, right? So typical cycles can be from 21 to 35 days. Typically, a healthier cycle is from 25 to 35 days. Atypical cycles may involve irregularities like a missed period, soaking through a pad or a tampon every 1 to 2 hours, so very heavy bleeding, bleeding greater than 7 days, cycle variability that, like, say you normally go 35 days, but now you're going 25 days, from month to month. That can indicate that there's a problem, even though it's within a healthier, range of days, what's considered healthy. It's about what's regular to you. If you're passing larger clots greater than a quarter, that can indicate abnormalities with your period. Bleeding that interferes with daily activities. If your period is stopping you from functioning, from working out, from going to work, from seeing your friends, that indicates that there's a problem. We should, because that comes about every month. We can't be feeling that way every month. I know some people say that's just part of being a woman, but it can indicate that there's underlying issues that you shouldn't have to live with that let's figure out what's going on and try to fix it and address it head on, right? It's not fun to feel that way, especially, 12 times a year. Of course, it can indicate anemia, our periods, especially if we're bleeding very heavily. So, of course, anemia meaning iron deficiency in this case, because anemia can indicate certain B vitamin deficiencies, especially B12. Understanding these variations is crucial for identifying our, potential health issues. Browner blood can indicate, it's moving along slower, for example, or it can indicate, the blood that your cycle shows can indicate different issues as well. So it's important to note that. Irregular cycles, of course, not just how we feel, but can indicate other medical issues going on like PCOS, thyroid disorders, hyperprolactinemia. I've had some patients have hyperprolactinemia and find out that they had a small pituitary tumor. Endometriosis, of course, under eating or REDS, significant weight changes can impact our period. Nutritional deficiencies, can be stress related. So, of course, if we're pushing towards cortisol, it's called the pregnenolone steal. Pregnenolone is a precursor hormone that helps to build different sex hormones, right? So, if your body is constantly in more fight or flight, so you want to think of parasympathetic versus the sympathetic nervous system, right? So, if you're pushing towards fight or flight and you're making cortisol all the time from pregnenolone, then your body's not using that pregnenolone to, when you're in that more rest and digest phase to make progesterone. It's constantly go, go, go. So if you're, pedal to the metal and you're very high stress and it's impacting your thyroid, it can also impact your progesterone. It can impact your pituitary gland in terms of your LH and your FSH secretion. And this is how, in part, among the many mechanisms for PCOS, chronic stress can impact those with PCOS, but also thyroid disturbance. When you're very stressed, you're using up more of other nutrients, or if you're low in other certain nutrients for your in regard to your thyroid, if you're low in, vitamin D, certain B vitamins, selenium, iodine, that goes to making different thyroid hormones. When those thyroid hormones are altered, that can also disrupt the chain of your menstrual cycle too, especially if you're pushing more towards cortisol and then not making other sex hormones. Of course, sleep impacts stress and our body's ability to grow and repair. Infection, of course. Irregular cycles can also indicate fibroids, right? Especially high estrogen, lots of heavy bleeding if it's not due to anemia. Fibroids are very common, not just breast fibroids, but also in lower reproductive tract, uterine fibroids, polyps, and adenomyosis. So the menstrual cycle reflects how well estrogen, progesterone, luteinizing hormone, and FSH are all syncing and working together as a team. I put an image of this book, The Fifth Vital Sign, up as it's a great tool to learn more about your body, especially if you want to get more in depth on this. I'll also share other tools later in the presentation. So your period may signal regular ovulation, right? Predictable cycles, moderate flow. I'm feeling good. Maybe there isn't much to hone in on. Lower progesterone can signal, a shorter luteal phase, right? That second half of our cycle, or spotting before our period. Higher estrogen can be indicative by heavier bleeding or breast tenderness, right? An androgen excess, which think like your male sex hormones like testosterone. If that's high, think PCOS, irregular periods, acne, and hair growth. So it's important to take note of what's going on in your body and bringing that up to your clinician, your registered dietitian, your primary care physician, your OBGYN, so that you can address this head on. You'll often see what's called primary and secondary estrogen dominance. So primary estrogen dominance is is one of the more common issues we find with women where they are producing a high amount of estrogen in general. Secondary estrogen dominance can happen when the body makes too much. Not doesn't not that it makes too much estrogen, it's that it's not making enough progesterone. So when you look at that relationship that we were talking about that we touched on earlier in the presentation, when estrogen starts to peak and progesterone's supposed to peak at the same time, but just a little higher. Let me go back here in the second half of the cycle. I hope my cursor you guys can see between days 18 and 26. So when we see that if progesterone's low, then it's not going up in a higher ratio compared to estrogen. It's actually, I call it like a rainbow or a small hill, lower than estrogen. So that's going to impact the balance between the two. So that's part where this term balancing your hormones comes from because it's also about the synergy between all of them together. So when that happens and you see more of a secondary estrogen dominance, that's typically indicative that estrogen's within range potentially, and that progesterone is low. Estrogen dominance can look like weight gain or an inability to lose weight. Estrogen's more prone for fat storage, right? Makes us more prone for fat storage. Heavy or irregular menstrual periods as it impacts our blood vessels. Heavy periods over 7 days. Headaches or migraines. Headaches or migraines during our period can also be indicative by inflammation. So when that uterine lining starts to shed, it releases what's called prostaglandins, which are similar to cytokines. They're like inflammatory molecules that can make us feel a little nauseous, can cause migraine symptoms. So sometimes symptoms can overlap that you want to, tease out. Of course, estrogen dominance can look like acne or rosacea, hair loss, mood swings, and irritability, breast tenderness, and more prone for fibroids or polyps, that tissue growth. Think of like fibrocytic breasts. Again, this is something we can test in the blood or with dried urine at Functional Nutrition RX. When we test this, we'll get more in depth, but we're very particular of the time of the month that we test, especially when we're looking at this dance between the two. Some causes that some causes potentially depending on the person could be that they're not ovulating. So if there's no ovulation, there could be low progesterone, right? Obesity, higher stress, right? So progesterone's being reduced because we're pushing that pregnenolone over to cortisol. Alcohol use can impact this. We're more prone for increased estrogen with alcohol use, insulin resistance, right? Having high insulin, higher increased likelihood for elevated blood sugars. That storage of body fat around the midsection as well is more prone with insulin resistance. Liver congestion, our body has to clear those estrogen metabolites. Estrogen breaks down to E2, E4 and E16. Genetics can impact that as well as our diet. There's certain nutrients that impact how estrogen breaks down in our body. And if you're breaking down estrogen to a more inflammatory metabolite, like E16, the higher the number, the more inflammatory, potentially more carcinogenic. It's a little harder for that liver to have to clear. Versus if we are more prone to pushing to like an E2 estrogen metabolite as it breaks down and passes through the body. It's harder to get rid of E16 than E2 as well. High dose estrogen medications, if you're on HRT or maybe you're not on the right contraceptive or birth control for you, can impact this. If you're in a post-pill cycle, so we call that post-pill anovulation. So maybe you're getting off the pill and it's common to not get your period for the first, 3 months for some, as this hypothalamic pituitary ovarian axis starts to reestablish, communication threads together, right? The pill disrupts that because now the pill is giving you hormones versus your body making those hormones. Neither good nor bad, but good to be aware of. Perimenopause can impact this if you're starting to reduce how much estradiol is being made by your ovaries, and we don't have a lot, coming from our adrenals, and especially as progesterone starts to decrease during perimenopause. Other things that can impact this estrogen dominance is xenoestrogens. This is starting to become a bigger and bigger topic. Xenoestrogens they come from different plastics, cosmetics, aerosols, that they are chemicals like BPA that can bind to hormone receptors and either cause, a hormone mimetic, where your body is creating this hyperbolized, likely estrogen response, or it's bound to that receptor and blocking the actual hormone from binding to the receptor and doing its job. So that's like, heating our food in plastics. Like many of us want to use a meal prep service to better our nutrition sometimes. And if, we're taking those and heating that up in the microwave, that might not be the best. So we always want to remember to try to use glass containers in the microwave. Even some glass containers have that plastic lid. Try to remove that, maybe put a little paper towel over it instead. Be aware of fragrances, lean on essential oils instead. Even some of your clothing, just to be aware of, and the different cosmetics and cleaning uh, chemicals that we do use on a day-to-day basis. So with regard to low progesterone, because this plays a role in secondary estrogen dominance, right? What can cause low progesterone is that we're not ovulating, maybe due to stress and that reduced functioning of the pituitary. Of course, that we're heading into perimenopause. There's less eggs being passed along. So when those eggs get passed along into that luteal phase, we're not creating that corpus luteum to create that progesterone. High cortisol, like we were saying, which is something that we can test here now at Functional Nutrition RX. You have to go to LabCorp. There are some labs that do test it, but in particular, we like to look at what's called a 6-point salivary cortisol curve, where you get the baggie of tubes from LabCorp. And it's often covered by insurance, which is fantastic. And each of those tubes contains cotton balls inside of them. And you'll take that cotton ball out and put it into the back of that cheek and let it saturate with saliva. You're going to do this at multiple time points throughout the day, within 5 minutes of waking, half hour, an hour to plot what your morning cortisol curve is for that day. You want to try to do it on what would be a typical day for you. And then you also do it in the second half of your day when cortisol should be going lower, which is, right before dinner, right before bed, and then if you wake up in the middle of the night to be the 6th point. That can help us to get data on your cortisol or your stress. Also looking at your thyroid. Yes, you can test cortisol in the blood, but it doesn't give you as big of a picture as plotting those multiple time points throughout the day. Also, checking in on a scale of 1 to 5, how stressed am I, right? Many of us can tell, if we're stressed or not, right? Sometimes we don't need a test to indicate that, but it is helpful to know, am I maybe in burnout or am I in high cortisol? There's different adaptogens that we work with to help based on the individual's results, and of course, different lifestyle tools. Thyroid dysfunction, especially hypothyroidism, can impact progesterone. Metabolic and lifestyle, of course, impacts us. So if we're under eating or have a low body fat, over exercising, right? Different forms of stress on the body. Chronic illness, poor sleep, or circadian rhythm, jet lag, right, can play a role into that. PCOS, often you want to test for, progesterone as well as estrogen and a bunch of other labs we'll get into. Post-pill transition could be temporary, but a key thing to note if you're questioning if you have low progesterone is checking in on your cycle length. Typically, you'll see a shorter luteal cycle or more spotting before your period. Signs can be anxiety or irritability as progesterone impacts our mood, insomnia, fibrocytic breasts, especially if progesterone's lower, estrogen and relationship might be higher. Menstrual cramping, mid-cycle spotting, difficulty maintaining pregnancy because we're not able to really build up that uterine lining, especially if we're trying to conceive. Heavy or painful periods because it's often that dance, right? So estrogen's now in a higher ratio to progesterone, so those periods might be a little heavier. PMS or PMDD. High progesterone, I don't see this often, but it's worth noting is that it can be done, it can happen accidentally through topical or bioidentical progesterone use, especially those going through perimenopause, menopause that are using hormone replacement therapy. Pregnancy, you'll see higher progesterone. Common symptoms could be, easy to cry, heightened emotional sensitivity, similar to other hormone imbalances, as we've noted. Similar breast tenderness is a common symptom that overlaps. Irritability, headaches, and fatigue, low sex drive as well. High androgens, especially in conversation regarding PCOS is really important to note. So irregular or absent periods can be a sign, acne, especially around the jawline or the chin, excess facial hair, it's called hirsutism, one of the signs of hirsutism. Typically, you could see that around the nipple, under the belly button, of course, along the jawline as well, or the cheeks. Thinning of the hair in the scalp, more oily skin. Uh, Weight gain around the abdomen can be indicative of some forms of PCOS. Difficulty ovulating and infertility with regard to high androgens. And common causes, of course, PCOS, insulin resistance, non-classic congenital adrenal hyperplasia, high DHEA, which is another precursor hormone that helps to make different hormones. Cushing syndrome, high prolactin, thyroid disturbances, and of course, certain medications like anabolic steroids. So, androgens are hormones like testosterone and DHEA that all women produce, men produce them too. But when levels become too high, they can impact, like we were saying, our cycle, our skin, our hair, and our metabolic function. Testosterone is very easily measured, and you want to look at total testosterone and free testosterone, which we will go into. So, as of 2023, the Rotterdam criteria had been revised, which is one of the main diagnosing criterias of PCOS. To diagnose PCOS, of course, dietitians, we cannot diagnose. We can, note symptoms and have you bring that up to your provider who does have diagnosing privileges. But it's worth to note that it requires two out of the three, after excluding other causes, like say Cushing's, for example, right, or thyroid disease. Two out of the three of the criteria below to diagnose PCOS. So ovulation dysfunction, irregular cycles. So ovulation dysfunction, so cycles less than 21 days, greater than 35 days, cycles, less than eight periods per year. All right. You might skip a period once or twice in the year, and that's, considered normal. Might have been, worth looking into what's been going on in my lifestyle that month if I do, skip a period, but it's considered to be less than eight cycles per year. 90 days for a cycle or greater than a year post menarche. Menarche, I can never say that correctly. Anovulation, suspected that you're not ovulating. Of course, you could be using test strips, and you can confirm with luteal progesterone if needed. That if your progesterone is very low, could indicate that you're not ovulating or you're not having that LH surge or you're not seeing the egg white like discharge. These are all clues about your ovulation. But ovulatory dysfunction is one of the criteria. So we're not getting our period or we have very irregular periods. Two is clinical and biochemical hyperandrogenism. So some providers interpret this differently. Some see it as you have to have biochemical indicators, like your labs are altered, or some, say, okay, I've seen some providers turn around and say, okay, I see signs of hirsutism. your labs are fine, but I'm seeing the physical manifestations of high testosterone, which so we might be catching this earlier before the labs start to change. So clinical or biochemical hyperandrogenism are signs of PCOS and one of the diagnosis criteria. So acne, especially along the jawline, hirsutism, androgenic alopecia, that thinning and loose, loss of the hair, are clinical physical symptoms of hyperandrogenism. Biochemical symptoms, elevated total or free testosterone, also DHEA hormone, which could be measured, or androstenedione. So these are all, androgens that, if elevated, can be indicative of PCOS. Hirsutism alone can help to predict biochemical androgenism. So maybe before it's going to happen, is what I was saying earlier. Again, it's worth talking to your provider about. Polycystic ovarian morphology. So you can have PCOS without having cysts. That is one of the most common myths I see all the time. Remember, two out of the three criteria, but the third piece of the criteria is diagnosed with ultrasound. So follicular number per ovary is often used where they count the follicles on the ovary and also are looking for cysts. AMH can be used, which we also measure here at the practice. That can tell you about the egg quality, amount of eggs in the ovaries. But if you do have irregular cycles and hyperandrogenism, that alone can help to diagnose for PCOS, especially in adolescence, where it might be hard to get an ultrasound or to, test AMH. Of course, you must meet, both of those criteria. So if you do meet those two criteria, sometimes the provider might not measure AMH or do the ultrasound just because you already have two of the three. So PCOS is a complex uh, system, hormonal disorder. So it involves like the brain, the pituitary hypothalamus, right? Communicating. So if we're overtly stressed and you're seeing imbalances with LH and FSH, like we were saying, of course, the ovaries and the theca cells can be changed due to this hyperproduction of androgenism that can change this like thickening of the ovaries. Of course, more androgen production can impact the liver. There's more testosterone for the liver to have to clear, which can impact our blood sugars. If we're more stressed, you typically see a higher increase in insulin and glucose as their barometers for stress on the body. So this is part why you see PCOS symptoms emerge when these systems create like a feedback loop of elevating the androgens, disrupting ovulation, and altering metabolism. So the pituitary, like we were saying, too much LH signal. This tells the ovaries to make more hormones if the LH is too high in relationship to FSH. So we're making more hormones. So that causes the ovaries to have this like thickening of the theca cells, making extra androgens. This causing more of that acne, irregular cycles, and hair changes. Insulin resistance makes the ovaries produce more androgens as well. And then the liver can't clear this as efficiently. High insulin lowers what's called sex hormone binding globulin. That's a hormone that binds to testosterone. And when that's bound to testosterone, it can't permeate into tissues as well and exhibit these sex characteristics. But when sex hormone binding globulin is low due to insulin being elevated, you see now that that testosterone can permeate into tissues. You have more free testosterone circulating the body and more likely to exhibit these signs of hirsutism. So it's all cascade together. And just because someone has PCOS doesn't always mean that they have the insulin resistance component. You see different body types with PCOS as well. So it can be, manifesting differently in the individual. So what is insulin resistance? So insulin rises and your body makes insulin to move sugar from your blood into your cells. With insulin resistance, your cells stop responding. So your body gets used to this higher amount of insulin being secreted. So it takes, more for the cells to open up and allow that sugar to enter the cell to be used for energy, right? How this impacts PCOS, we were saying, high insulin tells the ovaries to make more testosterone, more androgens, more testosterone, acne, hair growth, hair loss on the top of the head, right? Irregular cycles. High insulin also slows down weight loss. It makes it harder to lose weight, increased cravings for sugar. It lowers sex hormone binding globulin, as we just touched upon, and creates a loop where insulin's elevated, androgens are higher, and then when androgens are higher, more insulin resistance. Why it matters? Insulin resistance is treatable with nutrition, movement, stress reduction, sleep, as it's a barometer for stress on the body in part two. And sometimes different supplements or medication, of course, can also help with this. So there's a multi-prong way to attack this and then therefore improve symptoms of PCOS dramatically. The first step, though, in if you think you might have PCOS or irregularities in your cycle, you want to track your cycle, right? Utilizing mobile apps for tracking. Aura Ring also allows you to track your cycle. It measures your temperature. Flow is another great app. The Dutch test is a test that we will use here at the practice. Mira and Anito are newer tools that will allow you to use urine test strips to get barometers for different hormones like progesterone, luteinizing hormone. Birth control always comes up in this conversation, so it's important to touch on. Should someone with PCOS stop birth control? Well, that's not my place to say. That is a very personal decision between yourself and your medical provider, and not automatically, right? So, birth control can regulate our periods, helps to reduce acne and testosterone, those androgen symptoms, protect the uterine lining, and serve as a tool for contraception to prevent, of course, fertility if you're not trying to get pregnant. But it's important to know the pill does not fix the root issues of PCOS, like insulin resistance. So sometimes providers will put someone on the pill and give them metformin as a medication to help them solve this problem. However, once you come off that medication, symptoms may resume as it's artificial hormones versus solving the root issues going on in your body. Ovulation might take time to resume, as we said, if you're coming off the pill, and it can mask those underlying hormone patterns because now we shut off that body's communication loop and then we added artificial hormones in its place, depending on the contraception you are using. So this is a very personal decision, but it's important to have the information presented. So research shows that long-term hormonal contraception can lower different vitamins, as you see here. B vitamins, magnesium can cause more sluggishness with the liver because now the liver has to detoxify, of course, these hormones from the pill, but also can deplete because the liver is now having to detoxify and use nutrients to filter this out so that it can also deplete nutrients. Of course, women on the pill may benefit from focusing on repleting these nutrients like by eating a B vitamin-rich diet. Minerals from nuts and seeds and whole foods can be repleted, omega-3s, and by taking a high-quality multivitamin or prenatal, of course, a high-quality diet will help. So the bottom line is birth control can be helpful for controlling symptoms, but doesn't treat the underlying root, often for PCOS. Supporting nutrient status and metabolic health is important whether you stay on the pill or you transition off, no matter what. And like we were saying earlier, the challenge with hormones is a lot of hormones, like we said, have overlapping symptoms if high or low. But what's great is there's a lot of times like the similar solutions can help with different problems, right? So we want to look at this from a multi-prong approach between diet, lifestyle, supplementation, and of course, mental health. So it's about working within your interdisciplinary team. One of the first steps would be lab testing, like testing your total or free testosterone, like we were saying, your DHEA, those androgens, androstenedione, looking at your LH and FSH. Typically, that's tested in the first half of your cycle. You can measure sex hormone binding globulin. So if that's low in relation to high testosterone, that could tell you a little bit more, especially if there's liver stress. Progesterone. Of course, we want to measure that in the mid-luteal cycle. I typically have my patients measure progesterone and estrogen between days 19 to 21 if they have a regular 28-day cycle, and we adjust that window based on their typical cycle. Of course, AMH can tell you about egg quality, and if elevated and can be altered in many PCOS phenotypes. Insulin resistance, that can be easily measured along with A1C, lipid panel, of course, looking at your different metabolic risks, sex, thyroid panel, along with prolactin. Prolactin can help to be indicative there might be a pituitary gland tumor, if very high. So if you're seeing chronically prolactin is elevated, sometimes there is a different discharge from the nipples. That is definitely worth bringing up to your provider. Look at patterns, not single values. And of course, this is important to do within your healthcare team. Of course, there's also the Dutch test that looks at dried urine testing, which we also um, test here. So, of course, that's something that is covered by HSA, FSA funding. So, often these tests that I had already previously stated is covered by insurance. So, we like to be as minimally invasive as possible by doing this first and then looking at Dutch testing as needed after. Often it's not needed though, in this kind of situation. According to, PCOS clinical guidelines, consistency is more key, right? And of course, it's not about a single restrictive plan. It's about nutrient-dense eating. So what to eat to balance hormones. We're going to keep more simplistic here. And then, of course, we're going to go more in depth in subsequent presentations. And I will also share a podcast I did with a counterpart here, our lead personal trainer at Elevation Fitness, on how to exercise and how to support eating for each individual week of the cycle, just in lieu of time for today's presentation. But first and foremost, right, we want to start to eat 3 meals per day, right? Breakfast, lunch, dinner. Try to eat within a 12-hour eating pattern, right? Fasting can sometimes promote stress for menstruating women. Postmenopausal women, it's a little bit of a different story. You want to try to balance that blood sugar by including protein and/or healthy fat with every meal. Eat vegetables with each meal, provide fiber. We'll go more into fiber, but it helps to support insulin sensitivity and estrogen clearance. Limit processed packaged foods, right? Eat a whole food diet so that you can get more vitamins and minerals from that. When it's more processed, it's more depleted. Choose organic when possible because it's less likely to have hormone disrupting chemicals, i.e., glyphosates or Roundup, right? Which could bind to different hormone receptors and block their response or create, a mimetic effect, often a hyperbolized estrogen response. These habits also support, insulin, inflammation, healthy aging, ovulation, and hormone metabolism. This is a graphic I made a while back on, a general healthy anti-inflammatory diet. So PCOS is often linked with chronic low-grade inflammation or an elevated C-reactive protein. That's another great lab that we can test to get a sense of what is going on from a whole body inflammatory response. Not everyone needs all these labs done. It's just working with your provider to find out what labs are the right, tools to understand the situation that is going on in your case and based on the symptoms that you are presenting with. So based on this graphic, Fire burns hottest at the color blue, believe it or not. So think of the bluer colors on the outside of the that protein circle and starch circle as the more inflammatory foods. And as you go towards the center, the red are the foods that you want to have more frequently, right? Like a flame. So we want to try to eat a Mediterranean diet. So this circle represents our plate. We want to try to make half our plate colorful fruits and vegetables to get a variety of vitamins, minerals, and phytonutrients. We want to try to make 1/4 of our plate, our starches, try to aim for starchy vegetables like peas, corn, potatoes, sweet potatoes, most squash, or whole grains or beans or legumes, right? Of course, in the protein section, we want to try to eat mainly proteins that swim, fly, or grow from the ground. Eggs or beef, or we want to try to aim for pasture raised or wild caught fish. Of course, omega 3s, if you don't, how should I phrase this? You want to try to consume fatty fish at least 2 to 3 times per week, especially smaller mouth fish to reduce risk for heavy metals. So, if you don't take that in, you should try to supplement it because it's very hard to eat enough omega 3s from plant-based sources like the chia seeds I was mentioning earlier. I would have to eat pounds and pounds of that to be able to convert enough to utilize. So the marine-based forms are much more likely to be absorbed and properly utilized and contributes to that omega-3, omega-6 balance to reduce inflammation in the body. Of course, adding herbs and spices in are a part of an anti-inflammatory diet. Flavoring with herbs and spices directly competes with salt and sugar. And then we want to minimize trans fats, artificial trans fats, refined oils, and ultra processed foods to help us better follow an anti inflammatory diet. If you go onto our YouTube, Functional Nutrition RX, we have a lot more presentations just on this as a whole, as I know I'm going kind of quick. Carbohydrates and blood sugars. We also have a whole presentation just on carbohydrates and blood sugars alone and balancing blood sugars. But to summarize, right, you want to avoid large carb only meals. Like I was saying earlier, pair protein and or healthy fat with a high fiber carb. You want to consider, eating the protein and the veggie first in the meal. I like to start with the veggie as a volume eating tactic, like a salad before a meal to start to feel full, have the protein, and then a little fat, to cook with my starches. Lower glycemic patterns helps improve cravings and androgen excess. So by lower glycemic, you want to look below. On the left are our higher fiber carbs, and to the right are lower fiber carbs. Of course, if I don't eat enough of those higher fiber carbs, our brain still runs off glucose. You're going to be craving those lower fiber carbs, those easy to absorb sugars, by the end of the day. So we want to eat carbs that last. So, of course, um, fiber plays a key role in this too, and estrogen balance. So as I was saying earlier, those carbs on the end of the spectrum represent this blue line here on the graph on the bottom right. And those carbs that don't have a lot of fiber represent this red line. Fiber helps to slow down digestion as it moves through our body. And so as that food breaks down, that sugar is more likely to spike into our bloodstream if we don't have fiber or protein or healthy fats, slowing its trajectory, that sugar through our body and preventing it from dumping into our bloodstream all at once. When we bind our food with protein and or healthy fat, you could see this green line. We've got the apple with the peanut butter, a healthy fat source. So it's more complex for the body to break down, and you're less likely to have a blood sugar spike. So try to choose higher fiber foods, not just from a blood sugar standpoint, but it also and an insulin sensitivity standpoint. But the fiber acts as food for the gut and helps to clear estrogen through the body, helps to push it into the stool, and it helps to feed a healthy gut microbiota, which also helps to clear those estrogen metabolites as it breaks down and moves through our body. So this is just a fun slide on prebiotic fibers like onions, garlic, asparagus, and legumes that are great to pair with different probiotics. I love to recommend apple cider vinegar as a part of a salad dressing with, a salad that does have some onions on it, for example, or garlic in that dressing. Women with PCOS often suffer from lower microbial diversity. Supplementation. So these are a list of supplements, and I put their functioning in for you guys to read. This is important to go over with your healthcare provider and your registered dietitian. We don't want to willy-nilly take certain supplements like vitamin D, say if you have plenty of vitamin D in your body, which is rare, but it is fat soluble, so you can actually take too much. NAC people could take for no reason, especially if they don't need it. So you want to look at, what you actually need versus, spending unnecessary dollars sometimes. However, magnesium, many people do not get enough in their diet. Of course, the highest natural source of magnesium is pepitas, pumpkin seeds, and then chia seeds, and then spinach, but it can really help with cramps during our period. It's a very common deficiency. Berberine is very helpful, especially at night with insulin support, and is important to note. And as well as DIM is very helpful with estrogen metabolism. One that's not on here that's important to mention that I'm surprised I did not add is Vitex. If I'm seeing that someone has issues with their estrogen and progesterone balance, I do like to go towards Vitex as like a first line of support. Supplementation and support, right? We want to try to build supportive networks within our healthcare team, not just in choosing what supplements are correct, but also in terms of mental health. So, of course, many individuals with PCOS might be suffering with elevated stress levels. So, we do want to also foster an interdisciplinary healthcare team with our mental health provider, our dietitians, our personal trainers, and our physicians. So, if you're really interested in this topic and you want to go a lot more in depth, Anthony and I did a two-part menstrual cycle presentation on how to exercise and eat for each week of the cycle. Each of these podcasts here were at least an hour, and there is show notes. Tonight, you're going to get a meal plan for each week of the cycle to start. And then you'll see in subsequent months, we will do another presentation going more in depth on each week and how what specific even more specific foods you can pick to go more in depth. If this started to open up some questions for you, if we take your insurance for one-on-one counts for this seminar, we likely take it for one-on-one counseling, and rarely there is a copay. So give us a call, email us, message us on social media. We'd love to get you scheduled, or just give us a follow for, more seminars. But I want to ask everybody if there's any questions. And also, I want to thank you for your time, as I did go about 10 minutes over for tonight's presentation.
Hi, Amanda. I'm Paulette. I have a question.
Sup, how are you?
Good. I'm still breastfeeding, but I am interested in doing some sort of hormone test because I am noticing some of the symptoms listed in this presentation. So I was wondering if I am breastfeeding, can I do these types of tests now, or is this something I have to wait till I'm done breastfeeding?
Often it's once you get your period back, then you can
Okay.
testing. So absolutely. So some women breastfeed and it's rare, but they'll get their period.
Mhm.
So that's usually the time point that Christina and I wait for to test those hormones.
Okay.
That's a good question.
Um, and also, could you talk a little bit more? You mentioned the AMH test for egg quality.
Mhm.
What does that tell you about the egg?
It can tell you if there's more of a need for going deeper in terms of vitamin or mineral deficiencies to help, produce that follicle, or if there's issues to look deeper, maybe with progesterone or hormone balance. So it's just one of those clues.
Okay.
It's often an indicator for fertility status as well.
Okay.
Great
Great.
questions. I appreciate it.
Yeah. And I guess, sorry,
No, don't say sorry.
the third one is you mentioned a lot of tests. So if we were to do a consult, we could help narrow down some of the more important tests first.
Absolutely, not all at once. I agree. That's a lot of
Okay.
blood.
Okay. Thank
Great.
you. And
Nope.
thank you for a great presentation.
Oh, I really appreciate it. And thank you for your questions. I love it when people ask questions. And I hope you guys have a great night.
Thank you.
Thank you. Bye, guys. I'll send this recording out in 24 to 48 hours, just a heads up. Bye, guys.